Barack Obama decided that he would really like for some Americans in uniform to be seen helping out somewhere in the world without a gun. And so we did it, and it was also great. I mean, we were very needed. We saw a lot of patients. I mean, it was incredible. But a lot of the way that I think about certs actually comes from that experience. Because we were what they call boots on the ground day 3. We didn't actually start seeing patients until much longer than that for a lot of reasons. But every time that I saw a victim that had a compound fracture or it had a head injury, you know, things where there had been a lot of bleeding, somebody else saved their life on the day of the earthquake. We were there and we would get, you know, some special recognition, but actually it was the people who were around them at the time of the earthquake that were saving lives, because when somebody's bleeding heavily, they've got minutes to hours. And our beloved Berkeley Fire Department will not be there that soon. And that's why I'm an absolute believer in the CERT program. And I know that you guys will save even more lives in wonderful Berkeley Fire because you will be there. There's also a saying, kind of in the disaster world, that when there's a major earthquake, and if you need a rescue or you need assistance, the person who saves your life was probably within 15 feet of you when the earthquake happened. So wherever it is that you are, at the shopping center, at the kids' daycare, at the school, you know, that's where you're going to be you'll be giving help. You might not be back with your CERT team because you weren't at home or whatever. So these are the skills that I'm going to teach you. I hope to make them so that they seem intuitive, so that when you walk out of here, you can remember them, not because you sat and stared at your handout, and you're not going to have your handout with you, but because it's going to make sense that putting pressure for a long period of time is the way to slow down bleeding. And I'll explain why that makes sense medically. So anyway, so we were trying to have the slideshow up because that's always, you know, people like to stare at the screen. But actually, even if you don't even look at this, if you walk out of here, so the mantra that I teach the kids at summer camp at the YMCA in Richmond is, for bleeding, press hard, don't peek. And so they walk out of the gym, these kids that are this big walk out of the gymnasium going, press hard, don't peek, press hard, don't peek. And I taught it to the staff at MLK Middle School, and we came back like 5 years later, and I asked, you know, and I brought it up, and somebody from the back yelled, press hard, don't peek, and it just warmed my heart. So there are things like that that I'm hoping, you know, will sink in, so that at the moment you're going, oh my God, this is what I'm supposed to do. And because we will do it, it will help you to remember. And we are going to focus on bleeding for the reason that I just told you. You know, the splinting, the fractures, actually is wonderful for pain relief. But if they're not bleeding from the fracture, it actually could wait. It hurts like hell, but it probably won't kill them unless it has severed something that's bleeding. So that's why there's the focus on bleeding and treating for shock. And I can also tell you from the get-go, a lot of people are thinking, well, how am I going to remember all of these things? And what about burns? And what about this? And what about that? Even if all you do is remember about the bleeding, that's wonderful. Because that actually, in my mind and in my experience in Haiti, and you know, at certain other disasters, is the thing that has to be, you know, like done now. And you putting pressure on it and slowing it down now means that they might not even have to go to the emergency room, or they could go to the emergency room day after tomorrow when it's not quite so crazy. You know, and then recognizing which injuries are the ones that, I can do a little something, but that one is serious. You know, so that if somebody comes along and says, hi, I'm a doctor or a PA or an NP, or I do first aid, or I used to be a paramedic, then you could say, oh, these are my most serious patients, please look at these patients. So those are all where we're going to go. Okay, any questions on that so far? Okay. So disaster first aid is when there is no response to 911, or all you get is a busy signal, or your phone doesn't work, so you can't call 911. And so the way of thinking is to stabilize as much as possible rather than doing all of the definitive thing and doing the bandage and making it look all neat. You can do bandages and make them all neat, but that's not the main thing. And I already mentioned, so we're going to cover and spend the most time on controlling bleeding, and then treating for shock, which is actually remarkably easy. And I'll talk about splinting. If you want to learn advanced splinting, or your neighborhood group wants to learn, or your workplace wants to learn advanced splinting, I'm happy to come out. We're not going to do that today. And then something about moving victims and not moving victims, and if we are going to move them, kind of how we might do that. Okay. So one of the important concepts that's going to come up off and on is the triage categories of red, yellow, green, and then I'll also talk about a little bit about black and gray. So reds are immediates, and oftentimes it's not so much that it overlaps with being the most badly injured, but it's also has to do with something needs to be done now, as opposed to 20 minutes from now or in 2 hours. Somebody could have a severe brain injury, and that's really serious, but there's not much that you're going to be able to do in the field to make a difference, except to support them. But somebody else could be bleeding very heavily, and then what you do will make it will make a difference in terms of their likelihood of survival. So, but examples of reds are bleeding, shock, anything that, well, if they're having trouble breathing, that also is one, which is really more advanced, and we're not going to go over it today. So that's another thing that we could, I can come to your neighborhood group or whatever, but that takes more training. Yellows are injuries that are serious, but they can wait a little bit longer. So a fracture is one of those injuries. A broken bone is a serious injury. It's incredibly painful, but unless they're bleeding out, it actually can wait longer. And minor are things that, it may hurt, it may look ugly, it may be really, really scary, but if it's not bleeding heavily and it's just kind of yucky because it's dirty and stuff, it actually can wait, and you can kind of get to that later. In Hurricane Katrina, we had a lot of what we call grays, which were people who mostly were medically very fragile, and they were at risk of this event causing them to die earlier than they would otherwise, but there really wasn't much that we could do, with our skills. And with my DMAT team, even then there was almost nothing that we could do, because they needed to have advanced nursing care, which we did not have access to. We didn't have a soft bed with the humidity, and fluids and things like that with us. And then blacks would be people who are obviously dead. And a lot of people say, well, I can't make that decision. Well, you don't have to make that decision. But if you decide that they're not a red, then you're providing supportive care. And I've also, one of the things that I learned in going to a whole number of disasters is that the way that you treat the people who are not going to make it is really, really important. It's important to them, and it's important to their families. And for you to give them a name if you don't know their name, to have them logged as one of your patients, your victims, And to note that, you know, they were brought in at a certain time. We had somebody stay with them the whole time that they were, you know, that they were in our care. We had somebody sit and talk to them or whatever, because that's so important, both because sometimes they can still hear, and then also because then the family knows, oh, it was really, really sad, but it's so good to know that my daughter was not left alone. And that's doing a great deal. And you could also have your other victims help with that. You know, somebody who's a green or even a yellow that could really use some distraction, they can sit with somebody. So you may have been trained on triage tags. I find them impossible to use because there's no place to write the important information. But you've probably seen them, and you don't need to really worry, because one of the most useful things on them is the barcode, because they now electronically track people, hopefully. I mean, everybody in Katrina got lost for like weeks to months. Their family couldn't find them. So this has gotten better with the barcoding. But whatever entity comes to transport your victim out away from your certain place, will have these, so you don't need to worry. But we do use these because that way, you know, if you walk away or you go off of shift, where's my sister? Come on, June. Yeah. So I'm picking on her because she's been living with my cold germs all week, and she didn't get sick, so I don't have to worry about giving one of the rest of you my cold.
You don't have to apologize, she's your sister.
There you go, Carrie.
Let me take this off.
Yeah, why not? Because you have short sleeve underneath? Okay.
I think so. I can't remember. We'll find out.
Yep. Okay, so these are actually wonderful, and this system of keeping records that I'm going to show you, we perfected in Haiti and used it. So she's going to get tagged yellow. She has a compound fracture, something like that. So I'm going to put a yellow on there so that the whole team knows that she was at least initially triaged as yellow. And then you can use either art. I like duct tape because it's stickier. Then I used to advocate for artist tape, but now I use duct tape because I think it sticks better. So June is tag yellow. And then the other thing that we did in Haiti that was wonderful is that it's, I put the, so what time is it? Anybody know?
Oh,
6:53. 6:53.
Okay, so 6:50. Oh, okay. So I was asking what time it is, so it's 6:53 p.m. And I'm going to put her heart rate, I didn't do blood pressure, her heart rate, and kind of her mental status. She's alert. Yeah, and her heart rate was 72 because she's nervous because she's in front of all of these people. And she is bleeding, which I'm going to do in a minute, in her left arm. And then I just put... Oh, okay. And then this is... And I'm going to lift this on here so that if somebody else comes and checks on her in a half an hour, then she knows at 6:58 what the heart rate was, that she was alert. And so that if you wander away or somebody else comes to check, then they do another one, put the time on it, and And that way, somebody actually looking down the shirt can see that a victim either was initially alert and now is not, or was, you know, in a lot of pain and now is more comfortable. That progression is the type of thing that's very, very important for you to be able to see. And in Haiti, this worked, and my patients were so compliant. I'd send them home, tell them to come back in 2 days, and they would come back and the t-shirt is laundered, but the tapes are exactly where I put them. So anyway, I love this system, and then if you need to, you could take a photo of it, you know, if they're going to be transported and you want that record. Yes?
In some of the CERT classes in the past, they said something about putting tape, like on the rescuer's leg or something, and keeping track on who you treated. Is that not?
You could do that too.
Can you repeat the question?
So the question was, in a CERT class, they talked about the rescuer having tapes that they keep on their pants. I know the EMTs always use their gloves, but then what happens when they lose their gloves? But I actually did do that in Haiti and kept little pieces of paper in my pockets. So it's not a bad thing to do.
Had similar information to this?
It would depend upon what the rescuer values, but yes. But they would have it only for the people that they had taken care of. With this system, if somebody else then in the interim rechecks on a patient, then that information stays with the patient. So to me, if you can do both systems, and that would be wonderful. But to me, this one medically is a little bit better because that information stays with the patient. But keeping notes in your pocket, to me, is also important because then you remember what you were thinking. And that's what I always wanted to be able to do. You know, if 6 months from now somebody asked me, what were you thinking when you did such and such? I'll look for my little pieces of paper and say, I remember why I did that. You know, whether it was right or wrong, this is what I was thinking. And it's just helpful. But it's not a bad idea. Yeah. Yeah.
What did you write on the white paper on the other side, underneath the yellow tag?
Oh, so this is just her first name.
Oh, her name, okay.
Yeah. Could be first and last name. And if you change their triage status, I think it would be fine if you just put another tape partially over it so that you could see that they've been downgraded from a red to a yellow and then to a green, you know, or that they've been up. Technically, with triage tags, you never make them, I forget which way it goes. Yeah.
You used to say worse or better.
Yeah, you never change. Whereas to me, this method works a little bit better. So we're going to, yes?
So where does the triage tag go?
The triage tags, they usually go on the wrist. Yeah, when you use them. And go ahead and write it in just plain English. And if you need to write more, you can, don't write a book, but you know, you can just say what you were worried about. So we're gonna talk about controlling bleeding, and we're gonna make a mess, a little bit of a mess. While she's getting your picture taken. Now I'm gonna, in a minute we'll pass this out.
You know?
Yeah, you can go ahead and pass it out, because it's just, yeah.
Do you want us to do some trigger warnings?
Oh,
I suppose
yeah.
if you're worried about blood, you're probably...
Can you speak up, please? Thank you.
We're passing out some photos, and they are kind of gruesome because they're real, so...
So there's blood. I can tell you all of the people in the photograph. It's from the Boston Marathon. There's no mutilation. There's just blood. But for some people that is kind of upsetting to them. And everybody, June, can you come back here?
I was going to go show off my tags to other people.
Well, except I need you to
Okay.
do the next thing.
Okay.
So I wanted to demonstrate that when I'm talking about bleeding, you know, not all bleeding is the same. So the kind of everyday bleeding, you know, to me that's a dribble, okay? So that's something that we deal with, I don't know about every day, but, you know, so. But this, you know, you can kind of, it's not too dangerous to rinse off a little bit and then put a gauze on it and then hold on to it. And then this is what I would consider to be like a flow. And that, you know, takes more why don't you stand over here so we don't do the floor. And that's more where we really need to, you know, hold pressure for a long time. And we're going to talk about that. And then when you've got a puddle of blood, that's worrisome. That's, you know, that's getting close to hemorrhage or some version of hemorrhage. So let me see what I put on my notes. So when I see this kind of bleeding, you want to grab something, and then Dave, could you start passing, because we're going to use these in a little while, so that everybody gets 2 or 3 if there's enough.
Every group or everyone?
So every group, so every pair gets 2 or 3.
Groups of 4 maybe? 2?
Groups of 2 or 3 if we can, yeah. He's seen me do this before. So, so if she's bleeding like this, I'm going to put something on there. I'm going to grab something.
I'm going to pass out from looking at my own blood.
Yeah. And then I'm going to squeeze really, really hard. Now people often ask, well, I've been told to, you know, we should do elevation. And if, you know, if it's not a big wound, then yeah, you can, because you can get a good grip and squeeze. But if I'm having trouble with the bleeding, you know, so it bled right through. And we're going to do something else later on with this. You don't take that off. You put some more gauze over that. And then now this is where what I want to do is, if she hasn't already passed out, can you pull the chair over so she can sit down here? So what I want to do and what I want to have you practice is that what it feels like when your partner grabs and squeezes as hard as they can, and then also what it feels like when they're able to get both hands and put their weight into it. Does that feel, you can feel the difference?
Yeah.
So when I was in Indonesia after the tsunami, we did have some injuries, and one of the guys there was only 4 of us, was a Navy nurse who was big and strong. And I would tell him, hey, Pete, come over here. You do this. Because, you know, he could get a real grip on something and put a lot of pressure onto that. So what I want you guys to do is, with your partner, imagine that there's some blood there, and then takes anything absorbent, cover the wound. Yes? Only, in my mind, only if it's minor and if it's a part of the body that you can. Oh, so the question was, when do you do elevation? I only do elevation when it's convenient. it's really not as critical as getting it in a good position where you can really squeeze on it. Okay, so first, try squeezing it. And then put it on your leg or their leg. And put your weight into it. And you tell your partner whether you can feel the difference.
Yeah, using your weight instead of your muscle.
Or in addition to your muscle.
I have the issue. When I see blood, a lot of blood, sometimes I know to pass out.
What I found is we're going to undo this a little bit later.
That's got some intense. I do. Okay.
Okay, so so the question came up, if you could pay attention, because this actually was one of the things I was going to do in a minute. The question came up, how long do you hold it? And there's two answers to that. One is that for most bleeding, even if it's just minor, you really should hold it for 3 to 5 minutes. And one of the reasons, well, you know how when you have a nosebleed and you keep wiping it, it's because you keep opening the clot. So what you're doing when you're putting pressure is you're slowing down the blood flow so that that person's body has an opportunity to clot. You actually may not be able to stop the bleeding unless their body can clot. So there's two things about that. One is that even if you can't stop the bleeding, if you can get it slower and then slower, you are giving them a better chance at survival, giving their body a better chance to do what it needs to do, as opposed to letting it flow and then their body just cannot clot it. And then the other is that if they're on blood thinners, I haven't done any research recently, and I don't know what the newer products do, but I know that earlier on, most of the, there's some products, one of them that have chitin in it, which is made out of shellfish, and it's something that on its own causes blood clotting. It doesn't follow the same pathways as most of the blood thinners do. So at least it used to be that it still worked, and they also found that people who are allergic to shellfish do not have bad reactions to it. It just seems to, or maybe if they pull out the chitin and not the other things that are in the shellfish. But, so these are two brands. I don't have a preference for brands. One, yeah, it's a gauze.
Oh, wow.
So you don't, I feel like I've never had to use this. Yeah. It's the shell of the fish.
The shell of the fish.
Yeah. So the question, I guess, is it the fish? It's the shell of the shellfish. That's where the chitin is. And there's a process for purifying it, but it seems as though having allergies otherwise to eating shellfish does not seem to cross-react. So one of them is called Quick Clot. The other one is called Combat Zone. Oh, it's Quick Clot also. It just, they made it look very militaristic. Online. But, so it's the chitin. It's Carrie, you know how to,
Chitin is what the shell is made of. So it's kind of like if you could envision grout. You know, like if you put grout and it dries. So it dries.
Carrie, do you know how it's spelled?
I'm sorry?
C?
Oh, C-H-I. Yeah, C-H-I.
And there's actually a chitin that attaches to the rock.
Oh.
Many other,
So she's saying that there is a shellfish called chitin that attaches to rocks. So if you have somebody in your household who's on blood thinners, it could be useful. You shouldn't need it for like everyday injuries, but there could come a day that, you know, you're kind of glad that you had that available. But I don't think you need it for regular stuff.
So what material is better to use? Like if we have a towel, is that fine? If we have a t-shirt, like are there things that are better or worse to use?
Yeah, things that have holes in them. You know, so the question is, are there materials that are better to use? So gauze is actually great because there's a lot of places for the red blood cells to get caught in the gauze and to clot to each other. So if you have something of a really fine weave like this, it doesn't work quite as well. So if you're going to go and get something for your neighborhood caches, if you can get cheesecloth or muslin, where when you look at it, you can kind of see the light coming through, kind of an open weave muslin, I think works really well. Yeah.
So we have some stuff in our cache and it's expired, but they're all closed up, sealed. Can we just keep using that or keep storing it for use in an emergency? Bandages?
You have bandages that are expired? I don't know.
Use them for training.
Why would you use muslin from the grocery store?
It has to be very, very clean. And if you have it in your cache, unless you know for sure that your cache is perfectly, not getting any stuff in there. And,
Okay.
So,
I mean, worst to worst, you're going to use it, right?
right.
Worst comes to worst. We can't.
So the
I said if worst comes to worst, you're going to use it if it's expired. Yeah. But it really depends on if your gauze has been compromised in some way by leakage or rats getting in your cache or whatever. Just saying. It happens.
so you have same question or different question?
I was just going to add a comment. If you have something like bandaging materials or gauze that's expired, that just means that the sterility isn't guaranteed. But there's nothing sterile in the field anyway.
Right.
So like someone said, unless it's been water damaged and you're concerned about mold or something, the fact that the expiration in terms of bandaging materials just meant that they can't guarantee the sterility, and that the minute you open it, it's not sterile anyway, and it doesn't matter in this situation.
Yeah, so you said it perfectly. I hope everybody heard that. In the field, especially in earthquake situation, it just needs to be reasonably clean. And so that's all you're going for. But it reminds me of the question about expired water, okay? Please do not die of dehydration because your water was expired, okay? But what you should always do is, look at the water that you have available, and that goes along with bandages, that for the initial, if she got hit by a piece of concrete, it's all dirty. And so anything that I can use, and on the side of the freeway, I have asked guys to give me their t-shirts, to use on a wound. I didn't even know them, but that was what was going to be needed to stop the bleeding. But say you're getting down, you've irrigated it, you've cleaned it, and you really do want it to be, and you're going to do a final bandaging, this is like an hour or two, after you initially stop the bleeding, then get the cleanest bandage material in your cache. But for the initial, it really doesn't matter, and unless it's like been contaminated by rats or something like that. But with water and also with bandages, look at all of the waters that you have, and the cleanest ones are the ones that you should drink. And the ones that are like not so great, you can use them for cleaning or doing dishes, or, and as the event goes along, if you're not able to get better water, you just work your way down. So that at the beginning you use the cleanest water that you can find, and then a week later you're kind of using the water, because the water that you've put into those blue containers, if you look inside, and even if it's got mold, it will keep you alive. The mold just tastes musty. If it's slimy, that's a different thing. But, because when I've opened up a water bottle that's like 10 years past expiration, it tastes a little bit musty. But otherwise, when I'm on a hike, it keeps me going, and I don't get sick from it. So slimy is different, but I've actually not run into that problem. You had a question?
This is kind of the initial bandaging, and if you don't really have access, if you're with the person in your neighborhood and you think you're going to be there for at least 24 hours, so you're going to change this initial bandage?
Wow, you're way ahead of me on my PowerPoint. Yeah, I'm going to talk about that in a minute.
Can I ask a water question
Yeah.
since you're talking about it? Do you have recommendations for like how to cycle through your water so if you're trying to keep it like up to date?
Oh, yeah, so the question was, do I have recommendation for trying to cycle through your water? Both for your water and also for your food that you set aside in, your rolling garbage can. At least when my kids were little, they always did a food drive at the schools at Thanksgiving time. To me, that was a time to remind me to take those food, to buy a new set of, soups that I like and stuff like that, and donate those into, the food drive. So and then that can also be a reminder to recycle your water. But, I'm not good about remembering to refill my water things. So I, know though to prioritize for drinking the cleanest that you have available at the time. The other thing that I highly recommend is that you get a camp filter. A campsite type water filter, because I worked right next to public health, and I know that they are ready as soon as the earthquake happens to put out a notice to boil your water. Even if there's no documented problem, this is what public health does. So, and it's because they cannot guarantee that somewhere in the water system there isn't a break that would then contaminate the whole system, which is true. But it's going to happen even if there aren't any breaks. So if you have a camping filter, then you can take that water, run it through your camping filter, and not be quite so worried, and not have to use all of your fuel to boil it, And so I got the kind that, you pour a whole bunch in the top, and in an hour you've got a cup, several gallons. Go to REI, become a member if you aren't already a member. You have a question?
So I have a 55-gallon tank of water, and you can buy from the same supplier, you can buy what they call 5-year water preserve, and you put it in there, and I only changed it every 5 years.
So he has a water preserver that's good for 5 years, and he has a 55, which is huge, gallon tank to put it into. So do you know what's in the preservative?
I actually don't.
Okay.
It's a two-part chemical. You combine the two parts and they create a chlorine. chlora something.
right? So this gentleman's saying that it's got two parts. When you mix it together,
They guarantee the water is good for at least 5 years. But that's if it's sheltered from daylight.
So that's if it's so the water also needs to be sheltered from daylight, and it's a version of chlorine.
Well,
That
it's in a plastic container in a shed,
Right.
and of course it's completely.
Yeah, his is in a plastic container, an opaque one, I'm sure, in a shed, so that lends it to being, to lasting longer. Yes?
sells water and a water purification regime with it, and they claim that it will be good indefinitely.
Who is this?
Where?
Water and dessert.
I can't hear you. Oh, yeah, they sell the big barrels too.
Yeah, they sell small things and big things, and they give you a little thing of bleach, and they tell you how much to put in it, and they claim you can set it and forget it.
I'm gonna
Dave?
interrupt just because I'm worried we're not gonna get that through. So
Okay.
we go on our mailing list, do we always promote what she was talking about, which is La Miranda and El Cerrito's sale?
Water.
It's a great thing, but I'm just worried that we're getting too caught up in water for a moment, so.
Okay.
And I'm still
Thank you.
bleeding.
Yeah, so I'm hoping that everybody could feel the difference when your partner got their weight into it. So that's where the picture that I sent around, this is from the Boston Marathon. It's a real picture. All of the people in the picture did survive, because all of the people who survived the initial blast actually made it to the hospital and survived. But I saw it and I thought, that is a perfect example. So if you can, I'm going to send it, Dave, if you can send it around again, I want you to stare at this so that because the position that this guy is using, he's got both hands, he's got something absorbent underneath, both hands are on his leg, on her leg, and he's putting his weight into it. So this is a real example. And this is one of those things that when your mind is going blank, you can kind of sort of remember, I think it had something to do with this. This is what I want you to be able to remember when we leave. So there's two things that I want to do right now. One is that we mentioned the excellent question about 3 to 5 minutes. I would like somebody with a smartphone to set it for 3 minutes, but if you could shout out every 30 seconds, so half minute, 1 minute. And I'm going to talk a little bit very quickly about, so this works for extremities. Okay, the other thing is, if you really want this to be useful, is for one of you to grab the other person's arm and start squeezing, and squeeze for the full 3 minutes that she's gonna be.
She's timing now.
Okay. Let's start all over again. So if you want to realize how long 3 minutes are, grab and start squeezing. Or you can squeeze because 3 minutes is way longer than you would think. Okay, you want to start?
She's holding it.
Okay, so she's going to shout every 30 seconds, and you'll realize how long 3 minutes is. So I'm going to keep talking though. So if somebody has an abdominal injury, how long? 30 seconds. 30 seconds. So if somebody has an abdominal injury or a head injury that penetrates the skull, or the skull is broken, we don't want you doing that, the pressing hard. But what we do want you to do is to pack it by stuffing, this is my pocket. 1 minute, you're only a third of the way there. Keep squeezing. So, because you're getting too tired.
Feel it all easing out.
So you want to, so if there's an injury here, I want to be stuffing something absorbent into there, and you can put some gentle pressure there. So, but you could be making the injury worse if you're pressing on it hard.
1
But,
minute and a half. Sorry.
so you're halfway there. So you could, yeah, basically a gaping wound. So, but if by putting something in there that's absorbent, it gives their body something to at least start to clot around, and it improves their chances of survival. Question?
What if there's debris or shard glass?
Shards, so debris, shards of, she's asking about debris or shards of glass inside of the wound. That's a judgment call. You know, if it's inside of a wound that's, you know, all watery and you can kind of lift it out, I would lift it out. But if it's embedded in there or you can't tell, you want to work around it. So that if this was in my hand instead of between my fingers, you would wrap.
30 seconds left.
Keep squeezing. You would wrap around it and press around it like that. And with the skull, there are a lot of skull injuries. So if you can, is it 3 minutes yet?
8 more seconds.
8 more seconds. Squeeze hard.
We're done. Nice work,
Okay,
everybody.
so that's 3 minutes.
Does it hurt? How do you feel? Oh my God.
So,
I felt like finger marks on
yeah. So the point there is quite simply that it's a long time that you need to press in order to get the bleeding to stop. That it's a long time that you need to press, and it's going to feel like, oh, I know I've been pressing for half an hour, and really you haven't been. So
Your finger's blue, look, oh my God.
that's a beautiful shade of blue. I like that color. Okay, so one really quick difficult discussion about skull injuries. If you can, put a glove on your finger and kind of feel down there. You know, if there's skull down there, you can feel it. And then you can press really hard. But if if you're not sure that there's skull down there, then you need to just pack it. And put just put some gauze or something on there. Pardon me?
Intestines you don't put back in the cavity.
Oh, somebody's intestines are sticking out.
If somebody's intestines have come out, you don't put it back in the cavity. I think that's basically true. That you want to keep it moist, so you want to wrap it, and then you want to put the cleanest water that you can find, and you want to transport them as soon as possible. And hope that your block or the next block has a doctor who's a gastroenterologist who can advise you on that, because I'm not sure. Yes?
So just to clarify, you were saying don't put it back in or do?
Don't.
Don't put it back in the body. And then with the skull, you were saying just pack it with stuff, but don't put pressure, just pack it with something.
So if you can't find, if it was a pretty severe injury, and you suspect that the skull was broken, and when you put your finger in there, you're feeling something, you're kind of going skull, 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 mush, then unless it's a very small area of mush, you don't want to. But what you can do is that the scalp bleeds incredibly. I mean, I've seen blood all the way down into the shoes, and when I clean it all up and look, it's like a laceration that's that big. So you can put pressure on the part where you can feel skull. But just, because it's oftentimes all that blood is from the scalp rather than, it's not from the bone. But what you don't want to do is to be pushing something, obviously, into the brain. Right?
Would you pack that one?
So,
Did you pack it as well, that wound?
so I would put pressure, I would pack, if the part that you think, oh, I felt bone, bone, bone mush, then I would put something there, but not put pressure on it. Yeah. But then you could still put pressure around there to try to get the scalp to stop bleeding. Because the bleeding, if there's heavy bleeding, the bleeding's from the scalp. The brain isn't going to be gushing blood by itself. But there are other fluids in there that you don't want to be pushing around and messing with. And that is high priority. Let's keep going.
Just wanted to give you a time check, you're an hour in.
Okay. So I want to very quickly talk about, that she is clotted. So there'll come a point where you have looked at all of your reds and stabilized them. And we haven't talked about all of that, but for this part, that you've stabilized them, and your yellows, and somebody's taking care of the greens. And I made this big mess with all of these pieces of gauze on here, and she's feeling better, and she wants to go home. So what you want to do, can you hold this? I got too close to the amplifier. Is you want to wet it. Here we go. So that's why the towel's here.
So wet the gauze is close to the gauze closest to the wound.
Yeah, where it's clotted, where it's stuck, where there's blood. And then you'll actually need to walk away for a little while and then come back. And then you peel it like an onion. Okay? So, I don't know if you can see. But it'll be all stuck together. So I got this much off. Then I'm going to peel this part off. Now, if it starts to bleed again, if it oozes just a little bit, then just keep going. But if it starts to bleed again, that's where you want to stop. But you've gotten off most of it. And you might be able to get all of it off. Usually, if it's kind of thick, I'll have to peel some, put some more water on, walk away, come back. And hold on. Oh.
Oh, it's still actually stuck to it.
Great, thank
That's what happens. Yeah. That's what happens in practice, doesn't it? It sticks to it.
Yep. That's the whole point. I need a cough drop. Hold on. Sorry. And the last quick point is that the last quick point is that an excellent way to do the final rinse is to take one of the water bottles that has that translucent top and just poke holes in it. And this is actually what we used in Haiti on all of our patients. Hold on. And we just use drinking water. And I need some drinking water.
Want me to wipe it off?
Okay. So that actually is the longest and the most important thing. Pardon me?
They need to be stitched up.
Oh,
First aid doesn't do that.
that's actually a real good question. Hold on. The answer is it depends upon what services are available. So for survival, it does not need to be stitched up. And in fact, when wounds have been dirty, as soon as you stitch them up, you have increased their likelihood of dying of infection. So if it's a disaster where healthcare services will be available within a couple of days, you can send them off to get stitched up. But if it's a really big disaster, it's actually best to leave it open. The suturing is in order to give you a better scar. It has nothing to do with survival. Survival, actually, get it as clean as possible and leave it open. So if you can't get them to, don't feel badly if you can't get it sutured within the golden 6 hours. I mean, the emergency room where I trained, nobody was even seen within 6 hours, let alone sutured within 6 hours. So, question?
So just a quick recap. So if the wound, you've got the bandage, you irrigated it, it's clean, it's open, and you're just leaving it open to breathe, basically. You don't dress it.
Yeah, I would, if you're in a clean situation, you can leave it open. I would put a gauze on it. I would wrap a bandage just to keep it clean. And if there are edges, to put a snug bandage will keep the edges closer together, so that so that they're not gaping open quite as much, and that's helpful also. But suturing is excellent after surgery, but in a disaster, it's actually can be completely disastrous. Okay, so the only other thing I wanted to talk about is very briefly about tourniquets, which is for us, you don't. Because 95% of all bleeding can be controlled with direct pressure if you keep at it. It is so unusual to not be able to control bleeding. But it also depends upon how soon help will be available. So if there's something like the Boston Marathon, yes, if the rest of the healthcare system is available, slap that tourniquet on, get them there, and that tourniquet will be off within a few hours at the very longest, and that is fine. But if it's a major disaster, and it really is a major disaster, you should apply a tourniquet only to save a life. It's very dramatic to put one on, but once you put a tourniquet on, you must leave it in place. And I used to think, why? Because people talk about kind of opening it up to let a little blood through. And then I realized the basic medical reason is that once you cut off the circulation to a part of the body, then it starts to clot and necrose. In other words, the tissue's starting to die. It's putting out these really nasty lactic acid chemicals and things like that. And when you release the tourniquet, all of that flows back into the body to the heart. And that's when the patient dies. So once you put it, if the tourniquet's been on for like 3 minutes and you go, no, don't do that. 3 minutes, you can take the tourniquet off. But otherwise, once somebody's put that on, and tourniquets hurt like hell. So there is one other option, which is, the SWAT T, which I'm not which I'm not going to demonstrate today. But it's an elastic type bandage. I can come back and teach you about it. That is capable of it's possible to wrap it tight enough to act as a tourniquet, but you can also use it using less pressure, and you can get a nice smooth wrap around, and you can just kind of apply it enough to slow the bleeding, where you can feel like, okay, maybe the bleeding hasn't stopped, because if I had to crank it on to make it stop, but if the bleeding's slowing, that's good enough. And this is a really good, yeah.
What is that called?
It's a SWAT T, SWAT -T. And I haven't actually had to use them in the field, but I've heard people say that, yes, they're...
Could you use that instead of hand pressure? Like, could you use that if there were a lot of people and you couldn't spend 3 minutes before?
Yeah, so that's an excellent question. When would you want to use this as opposed to hand pressure? And I am thinking that if you've got 6 people who are bleeding and there's one of you, you start out with a direct pressure, kind of feel like, oh, okay, this is going to take a really long time, but I think it's working. Then you could wrap this real snug, not tourniquet, but it's real snug, and you feel like, okay, it's slowing down, and go on to the next patient.
Does that product adhere to itself? How does the product work? Does it adhere to itself?
You wrap it. You wrap it first over itself, and then you go, and you would be pulling on it really, really hard and stuff like that.
So what do you do at the end?
And then at the end, you tuck it under. Yeah.
Well, in fact, it says that on it.
Yeah. Yeah, and there's guides on here as to, what's tourniquet level and stuff like that. But this gives you a good option to applying exactly when you have too many victims, or you feel like, I'm losing, my hands are turning numb. But, so that's why I like it, and it's adjustable.
Barbara, how does that differ from vet wrap and the other elastic things that we can now get for humans?
Yeah, I think I've heard of vet wrap. There's also an Israeli bandage and things like that. I haven't done a side-by-side comparison, except that I really like it. Yeah.
Would you use the whole thing on a small aerial lamb, or would you cut it and...
No, I would use well, if it's a small area, I probably wouldn't even use it. I'm thinking a thigh is the likely place that you would need something like this. And also because if there's multiple places, then this can also then wrap a whole, several lacerations that are from the same injury. Yeah. Okay, so I want to talk about shock. And people oftentimes ask me, well, how do you know that somebody's in shock? Anybody who, you can kind of clear the table. So anybody who's had an injury, or even people who weren't that injured but saw a very, scary thing, can go into shock. There's many different mechanisms that are going on. But the bottom line is that anybody who's had a severe injury is at risk for going into shock. And the treatment is so easy and so basic. But classically, I'm standing here, I'm standing erect, I'm talking fairly fast, I'm making eye contact. Somebody who's in shock is likely to kind of lose that tone and focus. And if you were to ask them a question, it'd probably be slow to answer. Their gait might be a little bit off. So their skin might be pale. So those are signs, that, oh yeah, that kind of I think that's what that looked like. But the basic advice is that everybody who you've treated for an injury and should be put into a shock position. Because the shock position is basically lying down to go to sleep on your side. So, but the full way would be to have something underneath them, because the ground, especially in the Bay Area, tends to be cold, and you want them to not become, hypothermic. So I'm going to ask my sister to lie down on your side.
I thought you were going to come from the audience.
Yeah,
Lie on my side,
yeah, on the table.
facing them.
Yeah.
Maybe I should have guessed better.
What a sport.
Yeah, what a sport. So you want the knees bent, with one probably more bent than the other. And she already did this. She put her arm under her head so that the head is supported. And then you can put some blankets or something behind them so that they don't roll back over. But it is basically the fetal position or the curled up position. The knees being bent just to keep her on her side. If she passes out, then presumably she won't swallow her tongue. And you also want to keep them warm. Or if it's hot, you want to keep them cool. But if you get all of your victims at least sitting down, and then preferably on their side. After automobile accidents, I've had people who I think you really should be lying down. No. Well, just get them at least sitting down so that if they pass out, then they won't hit their head and hurt themselves. And then have somebody stay with them. And the instructions are stay with Sarah over here. And if she starts to tip over, then just, let her go over gently and let me know. Okay, but if you can remember lying down, blanket under, blanket over. Yes, good, Eva.
Is it specifically on the left side or in either side?
It doesn't matter that much. I think there's like that much difference if it's on the left side. So, shock, mysterious, complicated, but the treatment is always to get them horizontal. And that's just so basic and easy. Okay, and you can remember sleeping like a baby. Okay, where's my notes? Okay, we already did bandaging. The only thing I wanted to say about splinting is you've probably seen, the instructions about if the fracture's here, you want to mobilize below and above. And there's lots of things that you can use. But the other thing I want to explain to you is that you can also use the body as a splint. So if you have somebody who comes in and they're going, oh, it hurts, and you're going, ooh, I think that's broken. You do not need to rip their arm away from them and put it into, for one thing, they won't let you because it hurts so bad. If you breathe on it, they're ready to hit you. So if they are holding it against their body, it is being splinted. So all you need to do then is to wrap around that, or what you can do is support that. So that, then at a later point, they might feel better and they want you to put the splint on. But remember that the point is to not have the bone fragments moving. And many times just the patient will be doing it themselves. They'll be, lying in a certain position so that it doesn't move. It doesn't, no, don't move that. Then don't move it. And that's fine. That you don't have to put it into something else in order to do that. And especially if there are multiple injuries, whatever position they're in, If that is the most comfortable position that they can get into and they can breathe, then you can leave them, even though you're thinking, ooh, that looks really weird. That is what they have found is the least painful. So then put things around them so that they can relax and support them and keep them warm. But you don't have to put things into splints unless that.
Become a red? Would that be a red if they have multiple?
Multiple injuries, yes. If you can't quite figure out, no, that they got lots of injuries and they're not looking good, and you know, then that's a red, even though you can't pin it down. Absolutely.
Shock a red? Just shock automatically a red?
Yeah, because if they're going into shock, if they're being pale and unresponsive, that is a sign that you would want to move them into the red category. Yes.
That might be part of that too, but what if you suspect internal bleeding, or there might be internal injury?
If you suspect internal bleeding might be internal injuries, then they would be a red. Even though there's not a whole lot for you to do, they would be a red because, they would be high priority for transport, you know, or if somebody comes along, yes. But there isn't anything except to keep them supported. It's just supportive care. Good question. Yes.
What if you sense that they're about to faint? What should you do?
Get them onto the ground. The closer to the ground.
Yeah.
No, I would first get them down so they're at least sitting.
To prevent fainting?
So if they're standing, I would get them to a sitting position. Now, if they're in a chair and they don't want you to, you know, get them out of the chair, then yeah, if you can get their head down. But be prepared for the fact that when they pass out, they're going to roll off the chair. So be prepared for that. And if you can have somebody help you slide them off the chair onto the ground, then that would be even better. But if they're standing, then you want to get them, you know, next to a wall or have somebody else helping you to get them at least. Oftentimes I can talk people into sitting down first so that when they do pass out, it's easy to tilt them over. Yeah. Good questions. So how much time do we have? Not much, I know, but 8 minutes. Oh, wow. You could. So I want to talk about moving a victim. You really should move your victims only if there's a safety reason why you need to, not just for convenience or because you established your medical post down the street. So think about that. In earthquakes, you know, if they're inside of a building, then you do have a judgment call to make. But think about it before you move them. And I brought the stuff, but there isn't going to be time. But I just want to show you the devices. So you want to at least have blankets that you can use. And hopefully all of you have learned how to log roll. I can also come back. One of the fun things I can do is to do an evacuation training where we learn how to do carries and, you know, how to roll. And I've got a device at home where you can actually, you know, help roll. It's like a toboggan to get people down the stairs. Because I did this for my clinics in order to be able to get people down. But you do want to at least be able to log roll somebody onto their side, slide this underneath. But the problem with doing blankets is that when you're carrying them, you're using your finger muscles, which makes it, you know, those are not, because that's the thing that's holding the weight. And these, you know, if we actually did it, people go, oh wow, that's so much easier. These have webbing on one side, and they've got handles, and you can safely pick up you know, a much heavier person, because you're able to grab with this part of your hand or even get under here. You know when you see two people carrying a refrigerator, it's because they're using these muscles. But these are, this one is called a Mega Mover. Mega Mover, but there's a lot of different brands. It really doesn't matter the brand, it matters just that they have webbing and handles. And this one says that it will support 1,500 pounds. Well, that's fine and dandy, but you guys won't be able to lift more maybe 250 pounds. Beyond that, you really won't be able to lift them. You might be able to slide them somewhere, but then we would use some other devices. But these, I think, are really wonderful. And anybody willing to be log rolled? How many people know log rolls? We'll try to do it real quick. Okay, let's have somebody lie down on the floor here.
I'll do it.
Okay, you'll be the victim, or you'll lead?
I'll do the victim.
Okay, you'll be the victim. Who's willing to lead?
Sure.
Okay. And you can log roll them onto...
Yeah, tell me what I'm doing. I have no idea what I'm doing.
Log roll them onto here. Okay, who else has experienced log rolling? We need a team, 3 on each side.
I can't get that on the ground right.
Yeah,
now, so-
okay. Anybody else? Because there are a few other people who said that they kind of
So I'm
knew.
gonna log roll into this, right? Is that what you're saying? This is gonna go right next to him?
Yeah.
Right behind him?
So, I didn't want to cough on them. Okay, hold on, let me put on my mask. Dave, you know how to do this.
It's if you stand right in front of the microphone,
yeah,
it's
no.
going to give feedback, so.
Yeah.
I've done it before, but I
can learn if you tell me. I don't know how to do it, but I can learn if you direct me.
Oh, okay. Who's willing to be, Dave, you want to be head?
No.
Okay, so you could be blanket, and I'll coach you.
So is this an injured arm over here?
No.
Okay.
Just doing the log.
But we're going to roll that way.
So
But Dave calls.
So we're gonna roll him up like that, right?
Mhm.
Yeah.
You want help? You want me to be lifeless?
Lifeless.
On 3, ready? 1, 2, 3.
I see.
Do I push this under?
Yes. Okay.
Okay, yeah, that's far enough.
Back.
I see, there we go. Then we're gonna roll the other way.
Now you guys switch sides. You guys switch sides.
Yeah, I don't have the leverage yet.
Okay, you need, both of you need to switch sides. Because you're going to pull it towards you.
On 3, 1, 2, 3.
There we go.
Back.
There we go. Easy, log roll. There we go.
What a good man.
Okay. And then hold on. So you guys need to lift him up. June, you want to grab one?
Use your knees, not your back. Use your knees.
Okay, so you can, hold on. I'm going to lay this out. Okay, and you're going to move this way?
I know, right? I turned off the gravity machine.
Okay, now grab the handles.
Team leader, say 1, 2, 3 together. 1, 2, 3.
Very much. Okay, let him down easy. 1, 2, 3.
Let him down easy. Okay, so I want to wrap this up. With talking about what we call phases of death. So, and this is in your handout. But, and it somewhat overlaps with the immediate, with the red, yellow, and green, but not completely. But this was explained to me first. This concept has actually been around even before we had like the triage colors. But phase 1 are people where death would happen within minutes due to overwhelming and irreversible damage to vital organs. And a lot of those people are people that you cannot salvage yourself because you're not in an operating room and things like that. And then phase 2 is people who might die within several hours due to excessive bleeding or shock. And that is largely your reds, right? And then phase 3 is death in several days or weeks due to complicating conditions. The wound wasn't cleaned enough and they would then develop an infection, or their disease, their other underlying medical conditions would lead to other problems. And the reason why we, one lady kind of raised her hand once in one of my presentations. She said, I know, I heard that before, but the way that I learned it, those folks in phase 1, there's nothing you can do about it. And those folks in phase 2, no matter what you do, they're in phase 3, no matter what you do, they're going to be fine. And it's those folks in phase 2, that's where you got to concentrate. And those are the folks where you're going to make a difference. And I said, that is so good, the way that you explained it. So, so realizing that you will have some victims who are they need advanced medical care. And you don't have that, in your neighborhood. And to identify them, they're initially your reds, because you want to figure out what's going on. But you may figure out, wow, the internal injuries question, we don't know if it's internal injuries, but they're looking really shocky, they're looking really bad. But I don't see any bleeding. We're treating them for shock, and that is the best that we can do, except trying to get word out and to figure out if there's a way to transport them or a place to transport them. And there are people who are going to be yelling and screaming and jumping up and down and saying, it's bleeding, it's bleeding. But you assess that they're minors and that they can wait, and you need to be firm that there are these other people that I have to take care of first. And so you want to move your greens actually to another place that's not close to your folks who are doing the treatment if you can. And then be thinking all of the time, okay, this is how many people I have on my team. These are the victims that we have. Where can I do the most good? Triage is about doing the best for the most, using limited resources wisely. And so, people oftentimes say, oh, but I don't know how to do this, and I don't know what I'm going to, how to do that. As I said earlier, you have now learned some skills about controlling bleeding. And it is likely that those folks, a lot of those folks in that phase 2, where it's going to make a lot of difference, what you do is going to make a lot of difference, will be related to bleeding and shock. And so if you walk out of here with no other new skill than, okay, press hard, don't peek, have them lay down like they're sleeping, put something under them and keep them warm, then whatever, if you're able to do that, you will have done a lot to give those people a better chance at survival. And one of the things that I learned, actually was in Indonesia after the tsunami, is that sometimes there are folks who you think, oh my God, they're going to die. And they don't. And there are, and when we talked about it with, some of the folks in the village, they said, you guys are doctors, but the living and dying is up to Allah. And we said, and some of the doctors were, like, but I'm a surgeon, and other folks were like, yeah. So there's a lot more to it, but the fact that you were there and you did what you knew how to do. So I talk about staying in your lane. you know, and different people have different lanes. And I have different experiences than you. But stay in your lane, and if you do the things that you know how to do, and you did it with a good heart, then what you did was good. And, you know, don't feel like you needed to do something else. So don't try to do surgery in your driveway unless you know how to do that, right? And feel okay about it and support each other on your teams, that we're going to do what we know how to do. And for the people who are bleeding, we gave them a better chance of survival. We're going to keep an eye on them. And those who maybe aren't going to make it are going to be supported. They're going to have a name. We're going to, you know, be rooting for them. And that's as good as it gets. I've stopped at some auto accidents, you know, and they say, oh, thank you, thank you, thank you. And I said, well, you know, medically speaking, I really didn't do anything. And they always say, but you were there. And that's what matters. And sometimes they would ask me, well, you know, how can I repay you? I say, the next time that you see an auto accident with injuries, stop. And they say, but I don't know how to, and I go, and they say, yeah, but I'll be there. And I would have been with them, and they wouldn't have been alone. Okay, I get it. Yeah. Oh. So one very, very last thing is that if you find this exciting and interesting and you want more, take a wilderness first aid class. The Red Cross first aid classes tend to tell you, oh, call 911. And that's as far as it goes. Wilderness first aid teaches you, okay, you're on the side of the mountain, you've got this, and your buddy breaks their leg. And they do teach it they used to teach it at REI, I think they still do. There is a Wilderness Medicine Institute somewhere in the East Bay. It's really, really a worthwhile class. And they teach you to size it up, stop and think, take a deep breath, and then organize your team. So it's the best training that I can think of.
Coming up in like a week. Yeah.
So Gradiva said that there is a disaster first aid class. A wilderness first aid class. And be aware that sometimes there's a summer and a winter one. Do the summer one unless you are a ski buff, because they spend a lot of time on avalanches and hypothermia.
I've taken that class.
You've taken it? Okay.
So first of all, thank you again.
You're very welcome.
I would love a quick show of hands. Who would come back for an evacuation?
Oh, great.
I think that's that would be great.
Yeah, it's actually lots of fun because it's carrying and I think there's some stairs that we can bump people down. Yeah.
So thank you all for coming. I will be sending out to our email list the PDF of tonight's presentation, and we'll get the video up and going for you to share. But also, before you go, if you could take the chairs and stack them back up, that would be great.
Oh, yeah, put the bandages on the table.
BDPNN. If you Google it, that should get you to us, but it's BDPNN